The mission of Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We welcome you to our 2018 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and today we are pleased to be joined by Dr. Bradley Chips, who will talk about the Pediatric Asthma Yardstick. Dr. Chips received his medical degree from the University of Texas Medical Branch in Galveston in 1972. He was a pediatric resident for 2 years before serving in the Air Force at Ellsworth Air Force Base in South Dakota for 2 years as a general pediatrician. He then completed a combined allergy and pulmonary fellowship at Johns Hopkins and spent 1 year on the faculty in the Pediatric Respiratory Sciences Division. He has been in private practice in Sacramento since 1979. He is the medical director of respiratory therapy and the Cystic Fibrosis Center at Sutter Medical Center in Sacramento. He is also the Associate Medical Director of the Sutter Community Hospital's Sleep Laboratory, which he established in 1984. He is board certified in pediatric pulmonology and allergy and clinical immunology. He is the current president of the American College of Allergy, Asthma, and Immunology. Dr. Chips, we're so pleased to have you with us today, and we look forward to the information that you have to share with us today.
Thank you, and good afternoon, everyone. We're going to talk today about step care in children with asthma, and then for adolescents and asthma, describe the roles of the 3 currently available biologics for asthma. We know that there are genetic and environmental factors that contribute to asthma, which is a syndrome, and is not reflective. It is very heterogeneous. It's a disease that has many causes. Airway inflammation is the hallmark of asthma, with airway hyperresponsiveness, reversible airway obstruction, leading then to the symptoms that we know so well of cough, wheeze, dyspnea, and shortness of breath that occur in patients either intermittently with asthma or chronically with asthma. And we're going to investigate some of the interventions that are available at different age ranges, both for intermittent and persistent asthma. We know, though, that the patients believe that their asthma as well are mostly controlled most of the time. As you can see from this slide, the dark blue is my asthma is well controlled, the lighter blue mostly controlled and uncontrolled, and the very light blue. The problem is that patients overestimate their asthma control, and really they are almost the inverse approach to this when a validated tool is used to determine airway control in asthma. And in children with asthma, we have 2 such instruments that are validated that can be used. I was involved in the genesis of both of these tools. The first one is the TRACK tool for children 5 years of age and under. There are 5 questions, 4 in the impairment domain and 1 in the risk domain. It's 0 to 100 is the scoring range. 80 and above indicates good asthma control. Below 60, very poor asthma control. And the minimally important difference is a move of 10 or more in the scale. So since children, as I'll say again, with young children, preschool children, exacerbations really drive the boat here and not everyday symptoms. And we're going to discuss some ways that we can handle exacerbations in these children. Now, children 6 to 11 can use then the children's asthma control test, and 12 and above the adult asthma control test. In the children's asthma control test, there are 4 questions that the child answers and 3 that the caregiver answers. The scale is 0 to 27. 20 and above represents good asthma control. 19 to 15, not well-controlled asthma. And less than 15, very poorly controlled asthma. But all of these questions are just in the impairment domain and not in the risk domain. And in the asthma control test, there are 5 questions all in the impairment domain. So we know that airway inflammation is driven by innate lymphocyte cells 2 and Th2 lymphocyte cells that secrete IL-4, 5, and 13 that lead then to increased mucus production, smooth muscle hypertrophy, airway obstruction, and airway hyperreactivity, and changes in the epithelial surface of the airway. And this is also subtended by the eosinophil, in addition to the cytokines that are liberated through dendritic cell activation. We also, of course, have IgE, which is primarily involved with the allergic reaction, and the B cell epitopes that switch to produce plasma cells that produce IgE are very important in the whole pathogenesis of asthma. So we have a high T2 inflammation, and we also have a low inflammatory reaction, a T1 reaction, low T2, that is associated with poor response to inhaled steroids, cigarette smoke, airway infections, viruses, and bacteria, leading then to a lot of mediated release, IL-8 particularly, IL-22, 17, and 33, all and upregulation of interferon, all lead then to bronchial hyperresponsiveness, structural changes in the airway, and then bronchial hyperreactivity. We have no current biologics that will predictably decrease low type 2 or T1 inflammation, but we do have very good drugs that help with T2 inflammation. So, what are the asthma yardsticks? Well, as part of my presidential initiatives for the college this year, we are trying to rewrite the guidelines for the federal government, which were done in 2007 when EPR3 was published. So now we have 11 years later, we still need guidelines. So we have published adult asthma guidelines, which are the yardstick for adult asthma step-up care, that was published late last year. And then earlier this year, we published a pediatric asthma yardstick, and you can see these are all on open access and are available for downloading from the Annals of Allergy, Asthma, and Immunology. And these are the authors, co-authors that helped me with and provided most of the heavy lifting for this yardstick. And I'm now going to go through the step care for children less than 5, 5 to 11, and over 12. And the 5 to 11 and over 12 are very close to the same, and so we will not belabor that, but just deal with it sort of in total with that whole age range from 6 and above. So those were the things that we began looking at. And first we had to decide was there really a need for this. And I said earlier that the guidelines were 11 years old. The GINA guidelines, which are updated every year, are not read very commonly by U.S. practitioners. And so we were going to try to help define the step-up approach for not well-controlled or very poorly controlled asthma, and develop a tool that was responsive to understanding when sustained loss of control happens, how you approach that in your clinical practice. And 50% of patients who have asthma are not well controlled or poorly controlled. That's just almost the diametric opposite of what patients think about it. So when we use validated instruments, lung function testing, and cell nitric oxide to develop a paradigm to really understand how well asthma control is occurring, we see that many of the patients, 50% as I said, are not well controlled in regard to their asthma. So given that as a mindset, we have to first take a step back and look at why they're not experiencing good control. and that can be because they have poor adherence to medication. We know that that is rampant in the asthma community. Whether they have intermittent asthma or persistent asthma, still less than 30% of patients really have excellent refill histories with their medication. The average refill rate for single entity inhaled steroids, 2.3 refills per year, and for combination therapy, about 4 refills per year. So we have to make sure adherence is appropriate. We have to make sure that they're doing proper inhaler technique, that infection is, if it is occurring, is addressed, and that environmental control measures are also in place to make sure that clearly definable exposures to either allergens or irritants in the environment can be minimized. And then if patients do experience not well controlled or poorly controlled asthma for less than 1 week, we can use a combination of short-acting bronchodilator with or without an inhaled steroid and treat their acute loss of control or exacerbation, and no step up is needed. But if there's a prolonged period of time where, again, their asthma is not well controlled, 6 to 8 weeks, then we consider step-up therapy at that time. And let's first look at young children. We're going to use the GINA step care, which are 5 steps of care, and decide how one can approach this. So in a young child, this is 0 to 5 years of age, who is wheezing greater than 2 times per week and wakes up wheezing at least 1 time per month. And as I told you earlier, the minimally important difference for the track tool is a 10-point decrease in having 2 exacerbations a year. An exacerbation is the ATS-ERS definition of exacerbation, which is requiring oral steroid for at least 3 days in a row and needing visit or hospitalization. Then these patients, despite using as-needed inhaled corticosteroid or long-acting leukotriene receptor antagonist, then can use daily low-dose ICS or intermittent high-dose ICS. The intermittent high-dose ICS strategy was first described by Dr. Bob Zeiger in the New England Journal in 2011, where they used during an acute attack of asthma 1 milligram of budesonide twice a day along with albuterol. And this was a whole study of 1 year. And the patients treated intermittently with this paradigm patient profile I described did just as well as the patients treated every day with 0.5 milligrams of budesonide. So clearly there are young children who can be treated intermittently with asthma and who are not having symptoms in between time, where again, as I said, in young children, the primary manifestation of disease activity are exacerbations and not usually day-to-day symptoms. If step 2 is not appropriate, then we can increase the dose and they're still having symptoms more than twice during the week or once at night, or again, a decrease in their track score. We can double the low-dose ICS or add a LTRA, which is a leukotriene receptor antagonist, to their care. But we also should consider referral to a pediatric asthma specialist at that time. Then if we continue to have increase in symptoms, here we come to a problem because of a paucity of information that is in the peer-reviewed literature for children less than 5 years of age, and we can increase to a higher dose of ICS with an LTRA, or we can then begin to use combination products at 4 years of age and up. So ticozone propionate and salmeterol is approved at 4 years of age and up, and there's also published literature with budesonide and formoterol at this age range also. And my preference, of course, is to use combination therapy with ICS and LABA at this juncture. And So then, this is a busy slide, but it's a very important slide because it really captures our thought about patients with either episodic or multi-trigger persistent wheezing. On the left, you can see the patients who have episodic wheezing, if they have a positive asthma predictive index, and if they're boys, it was shown in the Teresa Gilbert study, the PEAK trial, that definitely exacerbations, hospitalizations, quality of life, all can be improved with daily steroid. Intermittent ICS can be used for patients who just have intermittent symptoms and are otherwise well in the intervening time frame. But you'll notice that females tend to have a much less pristine response to inhaled corticosteroid than the males did in that study. For non-atopic patients with a negative asthma predictive index, you can use a daily leukotriene receptor antagonist intermittently or with a regular schedule. And also the drug azithromycin can be used early in the course of wheezing. There are two separate studies, one by Beccaria et al. And one by Biscard et al. That were published 2 years ago that show us that a 12 milligram per kilogram dose of azithromycin given for either 3 days or 6 days early in the course of a lower respiratory tract infection, which is LRTI, can obviate the need for oral steroid. On the other side of this, patients with multi-triggered asthma, if they're atopic, daily inhaled corticosteroid is important. If they're non-atopic, though, you can use either ICS or LTRA intermittently or regularly in these patients. So the school-age children and the adolescents have very similar homology in terms of their treatment strategies. Again, now with children over 5 years of age with not well-controlled asthma, a validated instrument such as the PAC, ACQ, or Children's Asthma Control Test can be used. And these are for patients who need as-needed beta agonists at least 2 times per week, but not daily. You can wake up with their asthma at least 1 time a month. And these are also for children with infrequent asthma symptoms, but at high risk for exacerbation. And the greatest predictor for an exacerbation is having an exacerbation in the previous year or very poorly controlled asthma. These patients, again, do very well with low-dose ICS, but also they can use as-needed short-acting beta agonist and an ICS at the same time. And this is an emerging area that there will be studies. There are studies planned right now that will be instigated in the next 4 to 6 months, where a single inhaler short-acting beta agonist and ICS combination will be available to use for children like this when there is loss of control just proximal to an exacerbation. And again, as before, 1 to 3 month therapeutic trial is needed and reassessment in 2 to 5 weeks. If these patients then get to step 2 and are at step 2 and are not doing well, in order to step up to step 3, we have to make sure that we, again, as always, talk about adherence to therapy, inhaler technique, treatment of infection, and controlling any allergic or irritant stimuluses in the environment. But if they have symptoms that are greater than 1 month or more than 2 exacerbations, then we need, at this age, to switch to a low-dose ICS LABA therapy and or increase the dose of ICS or add an LTRA. So then we really have to step up our game at this point in time to make sure their asthma is well controlled. Then, if they're not responding to step 3 care in order to move to step 4 care, again, I won't repeat myself, it's the same scenario in regard to symptoms and exacerbations. Then we're beginning to have more arrows in our quiver to shoot at these people. We can increase the dose of inhaled steroid. We can add tiotropium in the soft mist inhaler. There are now studies published down to 1 year of age showing that the 2.5 microgram and the 5 microgram dose of tiotropium from the soft mist inhaler can be very effective as an add-on therapy. We can also switch to one of the 2 small particle inhaled corticosteroids that are available, either switch to or add either small particle beclomethasone dipropionate or small particle cyclosinide to these patients. Again, LTRA can be added, or more importantly, we can use budesonide formoterol as both a controller and reliever. To make sure you understand, this is not approved in the U.S. this indication, but is used throughout the world as fixed and reliever therapy. And there are multiple studies, I'll show you a couple of them in just a minute, that show that the strategy of an ICS and a LABA given at the same time, or an ICS and a short-acting beta agonist given at the same time, are much more effective than giving a much higher dose of inhaled steroid by itself. In a paper just published in May of this year in the New England Journal by Dr. Dan Jackson, evaluated a 4 times increase in dose of inhaled corticosteroid and found that by itself, without being linked to a bronchodilator, that there was not a salutary benefit in terms of decreasing prednisone use. So, this is a reanalysis of a very old study that Hans Bisgaard published, looking at budesonide given twice a day at a very high dose, plus terbutaline as needed, budesonide and formoterol given once a day with terbutaline as needed, and then budesonide and formoterol given once a day, and then also using the same inhaler for increase in symptoms. We just visually look at the exacerbations. You can see that the rate reduction was 46 to 53% in the SMART strategy was much better than either budesonide or budesonide formoterol used on a regular basis. So this is very, very important information I think we're going to see as an evolving trend in asthma care. This is, again, a complicated slide that Hans Bisgaard's group published this year in the ERJ, just showing that when looking at budesonide formoterol as maintenance and reliever strategy, it definitely outstripped the comparator in every instance. There are two separate figures in that paper. It shows you that that is a much more effective strategy in these patients with asthma. And you can see it in both of these, except for one paper. It is a very effective strategy. So then when stepping up from 4 to 5, we then use the same medications as stated before, but we also can use a biologic, which I'll talk about in just a minute. So there are really not too many differences in adolescents and school-aged children, but let me just take you through this quickly, the adolescent step care chart. For the first step 1 to step 2, virtually the same thing. Step 2 to 3, it's close to the same, except both of the formoterol inhaled steroid drugs are approved for children 12 years of age and older. So you not only have the fluticasone salmeterol approved, but also formoterol inhaled steroid preparations. Both of those are approved in this age range, and that is very important to keep that in mind. Also, this is the same as you saw for younger children, but I would also add a study that was published by Dr. Peter Gibson's group in the Lancet late last year, using azithromycin as an anti-inflammatory strategy on a regular basis in adolescents and young adults, and older adults for that matter, with asthma. They used azithromycin 500 milligrams given Monday, Wednesday, Friday. You can use 250 once a day or 500 Monday, Wednesday, Friday, the same dose, 250 milligram difference in a week. But this in both eosinophilic and non-eosinophilic asthma led to a significant decrease in exacerbations, slight improvement in lung function, and definite improvement in quality of life. So azithromycin can be added at this age range as a regular treatment strategy. And then when we get to step 5, in addition to the other things we've talked about, we then begin to think about using a biologic in patients with asthma. And first, we have omalizumab. Omalizumab has been around for clinical use for 16 years, for research for about 20 years, and is now approved down to age 6 for children who have recalcitrant asthma. So then in children and adolescents with moderate to severe allergic asthma, there's an IgE range for adolescents, 30 to 700, for children, 30 to 1300. They have to have an IgE in that range. They have to have documented IgE-mediated sensitivity, cutaneous, typo there obviously, by cutaneous or in vitro testing to a perennial allergen, such as house dust mite, animal dander, cockroach, or mold. They need to be still symptomatic, either poorly or very poorly controlled asthma with a validated instrument, as I showed you earlier, and are still experiencing exacerbations while taking high-dose anti-inflammatory therapy and also additional reliever medications. And again, as always, it's always very important to determine adherence, inhaler technique, infection treatment, comorbidity treatment, and control of irritant and allergic diathesis that may be causing their asthma. So children who fit this paradigm, agnostic of what their eosinophil count is, because it works in all ranges of eosinophil counts, can be used, omalizumab can be used at either 2 or 4 week intervals in the treatment of these patients as an add-on treatment. So that's one form of biologic therapy. The second form of biologic therapy are the anti-IL-5 drugs. Here, 2 of these drugs are currently available for the treatment of asthma. Mepolizumab is available in a 100 milligram dose once a month, and benralizumab is available. It's a 30 milligram dose, both are given subcutaneously, once a month for 3 months, then every 2 months. The symptomatic patient, again, who has poorly or not well-controlled asthma, and with a careful history using a validated instrument, is on high-dose ICS/LABA and other anti-inflammatory medications, who has a significant peripheral blood eosinophil and airway compartment eosinophil signal, and the peripheral blood compartment needs to be over 150, and the best responses are seen over 300 in patients who have a history of exacerbation, 1 or 2 in the previous year. And in these patients, the anti-IL-5 drugs have been shown to decrease exacerbations, improve quality of life, and improve lung function, and decrease oral steroid use. So I said 2 were available in children greater than 12 years of age. There is 1 available, reslizumab, which is only currently available in an IV preparation and only for patients 18 years of age and older. So we have these drugs that are currently available. We also have in the pipeline an anti-IL-4/13 drug, which is called dupilumab, which is already available for patients with atopic dermatitis and probably will be approved in October of this year for patients who have asthma. The other drugs are given in a medical office. It is possible that dupilumab will be approved to be given at home every 2 weeks, again for atopic dermatitis, after a loading dose of 600 milligrams. A 300 milligram dose is given every 2 weeks at home by the patient. I should also mention that for omalizumab, it's also quite effective for urticaria, for chronic spontaneous urticaria, and can be used for that diagnosis also. So we have talked about stepping up care for patients with asthma, and I've told you we published an adult asthma yardstick late last year, a pediatric yardstick this year. We're now in the second draft of the asthma step-down yardstick. So we've tried to provide to the prescribing healthcare practitioners a way to handle asthma getting out of control. But once the asthma has been controlled, we now are defining what the levels of asthma control should be and how the literature will direct us to having step-down care. And you can see on the screen the authors that are working with me on this project. And again, the editorial support by Dr. Judith Farrar is being given, and we hope to be able to present this for editorial review by October of this year, and hopefully we'll have it approved at that time. So, severe asthma is a significant global burden for health and healthcare. For asthma control leads to poor quality of life and very high direct and indirect costs. We spend a lot of money on asthma in the United States, and although we have definitely helped with the death rate for asthma, we have not dented emergency room visits yet. We've not dented the whole problem with asthma exacerbations. So the asthma yardstick is a comprehensive update on how to conduct a step-up approach therapy patients who have not well controlled or very poorly controlled asthma. And again, these yardsticks will need to be updated. And currently available, currently plans are in the January and June issue of the Annals of Allergy, Asthma, and Immunology will be updates to our yardsticks. They can also be downloaded free of charge and can be then married to the primary document, so we can see not only what we have to say in the primary document, but also the updates every 6 months. And also a very exciting area of patient education comes with shared decision-making. The adult shared decision-making instrument for asthma has already been finished, and the pediatric shared decision-making tool is in the work process now. This is a tool that helps patients and practitioners better understand the pros and cons of each of the available intervention strategies, and then can allow them to make a very clear decision about how to proceed with their care. I want to thank everyone. I want to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research.
Well, thank you so much, Dr. Chips. And I know that your talk today did help move the mission forward. So we totally appreciate that. We do have some questions for you today. The first question is, what tips do you have for parents who are sending a son off to college when their asthma is not controlled?
Well, first is to see an asthma specialist to try to get it under control. Second is to really have a heart-to-heart talk to them with the patient, which is an adolescent, and especially adolescents with Y chromosomes who tend not to take medicine very, very regularly. That mama's not going to be there anymore. You're going to have to do it yourself. And you may have to learn the hard way by having one or two exacerbations that you really need to take your medicine. And it has to be, one, to make sure that you use a national pharmacy chain so refills can be obtained, or do mail-in pharmacy, to make sure that an adequate supply of medication is given. And third, to make sure that an asthma action plan is filled out completely in plain English so the patient can understand how to react to loss of asthma control, which occurs before an asthma exacerbation.
Do you recommend an asthma action plan for children of all ages?
Yes, ma'am.
Absolutely. Okay, another question is doubling the dose of inhaled steroid every 6 hours instead of BID or twice a day during exacerbation effective?
No. In a word, no. And Dan Jackson's paper in the New England Journal proved that. We're really going to see progress using smart therapy, that is ICS LABA at the same time, and the short-acting beta agonist ICS preparation that is available, that is going to be available as soon as the studies are done. That is the timing of intervention with inhaled steroid needs to be linked to a bronchodilator to get a much greater salutary benefit than given ICS alone.
Okay, for Gina, step 3 and step 4, for children with uncontrolled asthma, would you add epitropium inhalation?
I can add ipratropium inhalation along with albuterol at the same time, the old Duolneb preparation, which is now generic, as long as the patient is not taking a long-acting anti-muscarinic medication. So, in essence, in answer to your question, if a patient is not receiving a long-acting anti-muscarinic agent, they definitely can use albuterol and ipratropium at the same time.
Okay, great. Okay, so when we're talking about intermittent inhaled corticosteroids, what is the period we should advise the parent to use it for? 1 month or less or more?
Well, the standard for using intermittent therapy is a week. So in the MIST protocol and the AIM protocol that were published both in the New England Journal, the treatment period was for 1 week. And then the stop in those patients who have just asthma associated with viral infections and are perfectly well in between times. Again, you have to make sure that you know the patient's history, how they respond, all those other moving parts. But usually 1 to 2 weeks is enough time to treat an acute event.
Okay, thank you for that. Okay, the next question is, can you speak to the FDA change in removing the black box warning on long-acting beta agonists used in combination for asthma? Did it remain for the LABAs as monotherapy? We have for some time noted that LABAs alone should not be considered for asthma controllers.
That is correct. LABAs are not appropriate for use singularly as an agent for asthma. It should be always linked to an inhaled corticosteroid. The boxed warning that was placed by the FDA on long-acting beta agonists, this is my personal opinion, was an ill-advised movement ill-advised move from day one and should never have been done. Having said that, it's very refreshing that the agency looked at the $2 billion they spent to prove something that most of us already knew, analyzed the data, and removed the black box warning. They should be congratulated for that, but it never should have been there to begin with.
Okay, thank you. And we do appreciate your opinion. The next question is, stepping down therapy can be scary for a parent and a patient. Do you have any suggestions or tips with talking with our parents and their patients?
Well, we're writing a whole paper about that. So in the next few minutes, I'm not going to be able to tell you all of that, but basically some of the high points are going to be that in stepping down, maintaining at least once a day long-acting beta agonist ICS is going to be important. The ICS dose should be decreased first, and you should be at low dose inhaled corticosteroid plus long-acting beta agonist as a step-down strategy first before you get to inhaled corticosteroid by itself. And as I showed you in the children's chart, that in non-allergic children, LTRAs can also be used intermittently in step-down care, but it must be very carefully watched.
Okay. Our next question is, what are the top issues for administering a biologic to pediatric patients, and how do you overcome these?
I don't understand the question. Try me again.
It was, I just hit delete. The question was, what are the considerations when giving a biologic medication to a pediatric patient, and how do you overcome that?
Well, you have to, in the poster child being omalizumab, you have to have that M&A, malignancy and anaphylaxis, as the primary concerns. And we know now, after 20 years of using omalizumab, that the incidence of anaphylaxis is about the same as with allergy immunotherapy, which is 1 to 200,000 shots. So that is not since most of these patients have already been on allergy immunotherapy, it's not really an added burden. And the malignancy issue has sort of it came into being in the 90s, and now with the Excel study, it's shown us in over 6,000 patients, there's just not a signal. There's absolutely not a signal. It's not one that we need to be concerned about. And I think it's just not a problem. And so that is very good. We are still required by the agency to provide epinephrine autoinjectors for patients with omalizumab, and that's fine. And I'm all for safety, but it's just practically not a concern. I've treated over 500 patients with omalizumab and only had one very severe reaction that turned out to be fine. But it definitely caught my attention, but it turned out to be fine.
Okay, great. Okay, do over-the-counter cold medicines mask potential asthma exacerbations and symptoms? For those parents that are not sure if they are treating allergy symptoms or cold symptoms, it's hard for them to tell sometimes.
Well, Primatene Mist shouldn't be on the market. That's number one. That's epinephrine. It's over-the-counter, and it should definitely be removed. My opinion, should be removed from the market. It can definitely mask airway inflammation and lead them to progressive airway inflammation that may not be recognized. So that's one. That's one over-the-counter medication. Over-the-counter medication that we should get rid of quickly. But the other over-the-counter medications, such as pseudoephedrine nasal steroid, antihistamines, phenylephrine, really they're temporizing medications. They don't change the natural history of the problem, and generally don't mask increasing symptoms.
Okay, that's good to know. Our next listener said, I totally agree with an asthma action plan for everyone, but wonders if there's any evidence to support that it's effective and that and effective as a part of asthma education.
Actually, when you look at the peer-reviewed data, you see that there really is not a huge body of evidence that shows that it makes a big difference. That's counterintuitive to what those of us in the trenches think. But if I sent you to the library to look for the data about asthma action plans being of a great benefit, you come back saying, why'd you waste my time? Because you just can't find it. So I think that, yes, I use them. Yes, I think they're important, but the peer-reviewed literature would not necessarily support that.
Okay, this is the next question. When providing education for parents of school-age children at a school open house, what information would you recommend that school nurses provide about asthma?
Well, I think you have to talk about adherence, number one. You have to talk about the fact that good inhaler technique is very important. And you have to talk about control of comorbidities and irritant and allergic predispositions to asthma. I think you have to talk about the usual common sense things that go into the management of asthma.
Okay, great, thank you. Do you recommend that all patients use a spacer with their inhaler? And if so, what kind of spacer? Most students in school do not use spacers with their inhalers.
I don't know what you're asking me.
Would you always recommend that a patient use a spacer with their inhaler, or is that something that you would look at specific situations for?
No, I recommend everybody use a spacer because it decreases the chance of oropharyngeal thrush. It also blocks the quick deposition of the excipient in the back of the throat, and improves hand coordination with inspiration with the meter-dose inhaler as it's actuated. So improving coordination and inspiration, because you can get adequate inspiration and deposition of the inhaled corticosteroid into the lower airway by 5 tidal breaths as opposed to 1 or 2 really deep breaths. So it allows them for younger children to use the inhaler with much greater safety and efficacy.
Thank you. Do you recommend a certain kind of spacer, or is that simply left up to the doctor's discretion?
Well, the vortex chamber is good. So is the aero chamber. So it's, it's just really just have to decide what you want to use and use it. Vortex or aero chamber are the best ones, I think.
Okay, great. Do you recommend a particular tool or questionnaire for school nurses to use with parents to determine the next step in care for students?
Yes, I recommend the 3 validated asthma control tools that I mentioned, which are Lesson 5 track, 5 to 11 children's asthma control test, and greater than 12 asthma control tests. They're all available in the public domain. They can download it from the web, and I think they're the best way to assure a good understanding of asthma control.
Okay, great. Someone is offering the information that Primatene Mist is not available in Maine. So there's one state that it's not available. It's not available, I know, in many, many areas across the country. And I do think
What is not available?
In the state of Maine.
What is not available there?
Primatene Mist.
Oh, good. I wish it was not available anywhere.
Oh, that's right. Okay, next question. With the amount of information available to be presented, how do you translate and effectively communicate to the patient and parent their role in achieving asthma control?
Well, I think it's using shared decision making is the best way to do it, where you analyze what are the positives as what medicines can be used and how they are appropriately used, and the negatives being the things I mentioned before: adherence, inhaler technique, treating comorbidities, and both allergic and irritational factors all need to be considered when developing an asthma management plan and trying to move forward.
Okay, great. Now, I think this will be our last question. Do you prefer one delivery system over another? And they're thinking about the DPI over the PMDIs.
I honestly prefer a PMDI with a spacer for most patients. The dry powder inhaler can be used. It definitely can be used, and if the patient prefers that, they most definitely get it. But if I had to take one to a desert island, I'd take a DPI, not a dry powder inhaler.
Okay, that's good to know. If I find myself on a desert island, I'll remember that. I'd like to thank everyone for listening today. Dr. Chips, thank you so much for joining us and not only presenting valuable information, but answering our questions as well. I'd like to ask.
Take care.
Thank you. Please join us next month for our October webinar, which will be part of our Latex Allergy Awareness Week offerings, when we welcome Dr. Kevin Kelly, who's going to present on latex allergy myths and truths, what the evidence reveals. This webinar will air on Thursday, October 11th at 4 p.m. Eastern Time. You can register for this webinar and on our website at allergyasthmanetwork.org. Look for education in the horizontal navigation bar near the top of the page and scroll to webinars. You can also review our archived webinars on this page of our website. At this time, please download the certificate from your control panel. If you have any difficulties, please email me using the link in your emails. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyrelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We hope you have a great and healthy day as we work to breathe better together.